All right, good morning, everybody. It's really wonderful to be here. This is an amazing conference, and thank you very much, Peter, for your very kind introduction. It's really special for me to be looking at a sea of faces from Maine instead of from a lot of different places. I was told when I came to Maine by somebody whose name will not be mentioned that I would last for 2 years. And then I would leave, like everybody else who comes to Maine professionally. They get hired, they come in, they do their job, they leave. And politics change, etc. Well, I didn't leave. I still live in Maine, and I totally love it. So I'm here to talk with you this morning about the ACE study. But before I begin, I want to make a couple of disclosures. And one that after Peter's introduction you probably already know, but I come with a deep conviction, perhaps radical to some, certainly back 27 years ago, or how many years ago it was when I worked with Maine, it was a radical perception that if we could prevent child abuse and neglect within 2 generations, we could reduce the DSM-4 to a pamphlet. I believe that, and we could empty our jails and our prisons. Okay? And the second disclosure I want to make to you is that I am really an ACE groupie. I'm very much an ACE groupie. I love the ACE study. I love it because it's aided me in understanding many of my own feelings and behaviors, and also the feelings and behaviors of others, including my own 4 grown children. With this understanding comes empathy and compassion, and with empathy and compassion come healing, even intergenerational healing. In addition, the ACE study findings reveal the central causative role of childhood trauma in all the other topics covered by this amazing conference: brain injury, disasters, addictions, military trauma, resiliency and healing and engaging with adversity, biology of psychological pain, collective trauma and community healing, trauma-informed treatment, consumer participation and experience, substance abuse, and the impact of substance abuse on children, the criminal justice system cutting, and other self-injury. Childhood adverse experiences are central to all of these issues and more. So that's why I am so happy for the opportunity to present to you today. Now let's see how this works. Okay. I'm not going to go over this slide. I probably don't have enough time to do that. But just to name who the people are in this slide, these are really my heroes. All of them are authors. I have other heroes who are not authors. But these are some of the people that influenced me greatly throughout my career. From left to right, Gaber, I don't know how to pronounce his name. Is it Gaber Mate? Some of you must know him. Do any of you know who Gaber Mate is? He's just written some amazing books. One of his is in the realm of hungry ghosts. And it's about addiction, and you've got to read it. It's well written, interesting, holds your attention, gripping, everything else. Bessel van der Kolk, he's come to Maine and presented. Who else? Across from him, or down from Bessel van der Kolk, is Peter Levine, who works with people who have trauma histories through the way it's stored within their body. Alice Miller, who's an incredible force in the field. Maya Angelou, some of you might know her. Let's see, Bruce Perry to the left in the middle, or to the right in the middle, who's wrote a book called The Boy Who Was Raised as a Dog. And I didn't understand really about neurological development until I read that book. It's just full of stories intertwined with what the research tells us about how trauma impacts on our brain and our nervous system. And finally, I began to really get it. It's interesting reading, and it helps you to really understand the neuroscience perspective on all this, which is very important. And of course, in the middle, there's Sigmund Freud, and I know he cupped out, Peter. I know he did. And still, I read his article, and I reread it every now and then, The Etiology of Hysteria. And it's profound. I mean, he felt he found the source of denial generations ago. And of course, he got ignored because the world wasn't ready for his findings. Judith Herman, another person who is a great force in the field. She's written a wonderful book called Trauma and Recovery. Toni Morrison, to the far right. She wrote a book called Beloved that opened my eyes forever as the intergenerational impact of slavery. Unbelievable work. Toni Morrison. Alice Walker at the bottom wrote a book called, I've forgotten the name of it now. Anyhow, she opened my eyes to, no, it wasn't just that. It was On Possessing the Secret of Joy. On Possessing the Secret of Joy. It was just profound for me. She really opened my eyes, and it's causing me to take a great interest in some of the, in fact, I plan on going to Kenya around this issue. There are girls running away from female genital mutilation. And she brought that issue to the forefront. The A-Study investigators are two of my heroes, Dr. Robert Anda and Dr. Vincent Felitti. And then there's Annie Rogers, who was one of the first people to come to the state of Maine, and Sandra Bloom, who is incredible. So I'm not, I could have told you about each person, but I don't think I want to make sure that I really give you the meat and potatoes of the A-Study. So I'm going to be throwing a lot of data your way. And do you have slides for handouts? Okay, good. All right, I'm going to ask you now just to do a little bit of reflection. There's a continuum there, and the question I want to ask is substance abuse and addiction more a disease or more a manifestation of childhood adverse experiences or trauma? So where are you now? Are you down towards the 1, which is a real conviction that it is a disease, okay? And are you more towards the 10, which is a real conviction that the root cause is trauma? All right, just sort of give yourself a little indicator there. And then go to mental illness. Is mental illness more a disease or more a manifestation of childhood trauma? And just kind of give yourself, I'm not going to ask you to share it. This is just for your own. And also I'm going to check at the end and see if those perceptions or those mental frameworks have changed at the end of my presentation. Okay, adverse childhood experiences study. Numerous studies have documented ways in which unaddressed childhood trauma affects our adult lives. The most notable among these is the Adverse Childhood Experiences Study. How many of you have heard about this study? Okay, well, I'm glad it's not the whole room because I love introducing their findings to you. I really do. They're profound and they can't be denied. We can't keep sweeping this issue under the rug. We've got to get our courage up and actually talk about it and address it. Okay. The findings of this study are critically important for all of us, no matter what our personal or professional involvement with children and adults is. So it's important to me with my family and my children as much as it is important professionally with other people. Our childhood experiences set the stage for what we become later in life. Adverse childhood experiences, when not recognized or addressed, often have lifelong negative impacts on our health and well-being. This is increasingly now being recognized as a major public health issue. Now I'm going to start my presentation with a personal story. It's the story of a young woman, my daughter Anna. This is a picture of her in her early 20s. On the left side of this slide is a picture of Anna at age 1.5. Can you all see the slide? Okay. The photo on the right is Anna years later in a state mental institution. The question to ask, what happened to her? These are various pictures of her during her life. At less than 3 years old, Anna was sexually abused. The abuse was severe, sadistic, perpetrated by a trusted caregiver, occurred at an early developmental age, and continued for nearly 4 years. None of us were aware of or intervened in what was happening to her. She did not have the language. Nobody taught her. She didn't have the language to tell. and we did not recognize the signs. This was in the 1960s, when sexual abuse was never spoken about. And I'm here to tell you, it's still a taboo subject, right? We don't talk about it. Numerous additional traumas occurred throughout her childhood and adolescence, overwhelming her already severely compromised resiliency. These included her experience with my alcoholism and depression, her father's violence, and a frequently chaotic family environment. Her 4 siblings, none of whom experienced child sexual abuse, as Anna did, were resilient enough to survive and thrive despite these traumas. Anna, however, broke at the age of 13, was misdiagnosed, schizophrenic, and began psychiatric treatment. Through her childhood, adolescent, and teenage years, she interacted with multiple health and human service systems, and many very good individuals tried to help her. But no one asked or looked into what might have happened to her. Rather, the focus was on what was wrong with her. Was she learning disabled? Did she have a mental illness? What was her diagnosis? How can we help her control or manage her symptoms and behaviors? For 17 years, she was in the mental health system, 11 of those years in mental institutions. She didn't drink or drug, but she did self-harm and made multiple suicide attempts throughout her life. During periods of homelessness, she would steal food and other items or confront people, excuse me, in a threatening way, bringing her into contact with the correctional system. At times, her rage and fear would overwhelm her. Though never physically violent to others, she would attack with words and yelling and destroy things. She was always suspicious that others were out to get her. Perfectly understandable. For 17 years, no psychiatric treatments, alternative therapies, mental health services, or medications helped her. 4 years, in fact, what passed for treatment triggered, re-traumatized her, and made her even sicker. When she was 23, she learned from other patients for the first time in her life. She learned that she was not the only one in the world to have been sexually abused. People live in isolation with this issue. Throughout her long history in the mental health system, although she requested help for her trauma and diagnosed herself to have PTSD, her requests were ignored. She was never assessed or treated for trauma. When she attempted to communicate the awful things that had happened to her, there was no one in the service system to listen, understand, or help her. No one had trauma training, and the system was not financially structured to support that kind of treatment. As a result, she was continually misdiagnosed and considered to be chronically mentally ill. She felt alone, unseen, and unheard, and no hope of healing was held out for her. She took her life October 24th, 1992, at the age of 32, on the back ward of a state mental institution. The emotional cost to us and her family was devastating. The lifetime financial cost of her care was over $5 million. The majority of people in our mental health, substance abuse, human service, and correctional service systems can tell very similar stories about their own childhood experience if we but ask them to. Though the lives of many do not end in the tragedy my daughter's life did, the impacts of traumatic childhood experiences, when not recognized, intervened in, or responded to, can be severe and can last over the lifespan. And this is what the ACE study clearly demonstrates. So, the Adverse Childhood Experience Study. This is a 14-year, and more than that now, collaboration between the Center for Disease Control and Kaiser Permanente's Department of Preventative Medicine in San Diego. It is the largest study of its kind ever done. Its findings are groundbreaking and are being discussed all over the world today. The findings challenge our current paradigms of thinking. The study revealed a powerful and undeniable dose-response relationship between traumatic stress in childhood and the leading causes of morbidity, mortality, and disability in the United States. The study involved over 17,000 middle-class Americans with Kaiser health insurance. They each responded to 10 questions about adverse experiences in their childhoods from birth to age 18. The questions are in your handout. It's one-page handout. The extent to which these experiences related to adult well-being, social function, health risk, disease, and life expectancy was then examined by thorough reviews of their comprehensive health records kept by Kaiser over years. About 70 articles have been published about this study, and on the Anna Institute website, the address for which is in your slides, you can download full articles of about 50 of these studies. Professional articles are hard to find. You go and they want you to register and pay $22 for 10 pages of an article. So we've figured out ways to download a lot of these articles fully, and you can have access to them through that website. Now, the story of how this study came about is, I think, pretty interesting. In the mid-1980s, Dr. Felitti of Kaiser noted a pattern occurring in their weight loss program for morbidly obese people. In spite of their success in losing significant amounts of weight, up to 300 pounds during a year, many participants dropped out of the program just as they were successful in losing the weight. In an attempt to understand why, Dr. Felitti and his colleagues conducted detailed life interviews with 286 of these individuals. To their great surprise, they learned that childhood sexual abuse was remarkably common and, if present, always antedated the onset of the obesity. No one previously had sought this kind of medical information, but many patients spoke of their conscious awareness of an association between abuse and obesity. How being overweight served to comfort or protect them or cause them to feel safe. Some told of instances where they had brought up their history of abuse only to have the information rejected by a physician as being in the distant past and hence of no relevance to current problems. The counterintuitive aspect was that for many people, obesity was not their problem. Rather, it was their protective solution to problems that previously had never been acknowledged to anybody. Dr. Felitti and his colleague, Anda, an epidemiologist at the Center for Disease Control, wondered if this pattern linking childhood abuse to obesity was common to other health risks and conditions. Their curiosity is what led to the ACE study. And I'm here to tell you, knowing both of these gentlemen, that they were blown away by the results. They did not expect to find what they found. So I'm going to give you a lot of material. Some of it you can use, some of it you won't be able to use. Some will connect to some people, not to others. But what I'll do is post this on the Anna website. You are welcome to take the slides and use them in your own. If you go back and train staff, use them. The notes will be on the website as well, so you can have my notes that explain what the slides are about. So who were the participants? The 17,000 HMO members who were interviewed for the ACE study were middle-class people with jobs and health insurance, not likely had to have been exposed to street violence, extreme poverty, malnutrition, dislocation, and war terror. So they can't be dismissed as atypical or aberrant or at-risk population. They are us, okay? Of these HMO members, 80% were white, including Hispanic, 10% black, 10% Asian, about half were men, half were women, 74% had attended college, and 62% were 50 or older. The average age was 57. The two most important findings of the ACE study are that these adverse experiences in childhood, one, are vastly more common than recognized or acknowledged, and two, have a powerful relationship to adult health and well-being half a century later. Now, this is a no-no. You never use this much information on a slide, right? So you've got it in your handouts. You've got this slide in your handouts. And people use it a lot because it captures on one page pretty much the essence of what the ACE study says. So it's an overview. What the chart shows is that in the first column, adverse childhood experiences lead to, in the second column, neurobiological and health risk impacts. And then in the third column, in turn, these lead to long-term health and social problems. What they found is that the more types or categories of ACEs, which stands for adverse childhood experiences, the greater the neurobiological impacts and health risks, and the more serious the lifelong consequences. Now, this is what is shown in the first column of your chart. Participants were asked 10 questions about these 10 categories of adverse childhood experiences. Can you hear me okay? Okay. That included abuse of the child, emotional abuse, physical abuse, contact sexual abuse, neglect of the child, emotional neglect, physical neglect, and trauma in the child's household, alcohol or drug use by somebody in the household, depressed, emotionally disturbed, or suicidal household member, mother treated violently, domestic violence, an imprisoned household member, and the loss of a parent through divorce, separation, or abandonment. A person's ACE score, you get an ACE score from 1 to 10, or 0 to 10, I should say, is based on the number of categories of adverse childhood experiences identified in childhood. So if as a child you were physically abused, that counts as a score of 1. Even if you were physically abused 250 times, you get a score of 1. Okay? If you were sexually abused, that's a score of 1. If you were physically neglected, that's a score of 1. If there was a household member in your childhood who was an alcoholic or drug abuser, that's a 1. Okay? So each one gets a score of 1. The ACE questions, again, are listed on the back of your chart. Anna had a score of 7, by the way, and I have a score of 5. Adverse childhood experiences are exceedingly common. As we've said before, 2/3 of this middle-class population of Kaiser members had experienced at least one category of ACEs. 1 in 6 had an ACE score of 4 or higher. 27% experienced alcohol or drug use by a household member. 25% of the women reported sexual abuse as children. That's 1 out of every 4 women in this room. And 17% of men reported sexual abuse in childhood. That's 1 out of every 6 men in this room. And men underreport. 66% of the women reported being abused in family violence in childhood. That's 2 of every 3 of us in this room. Women were 50% more likely than men to have an ACE score of 5 or more and had higher scores in all types of ACEs, except for physical abuse and physical neglect, in which men had much higher scores. Adverse childhood experiences are highly interrelated. An initial analysis of the data showed that ACEs tend to be highly combined. These figures illustrate how growing up with alcohol abuse in the home is strongly related to the risk of experiencing other categories of ACEs. The first little slide over here shows how the more persons abusing alcohol in the child's home, the more likely for emotional, physical, and sexual abuse to have also occurred. And as the second graph shows, the more likely the child is to also experience other ACEs, the mother treated violently, mental illness, drug use, suicide attempts, and a member of the household in prison. Now we come to column 2 of that obnoxious graph that I gave you, or that chart with the 3 columns, okay? And in column 2 are the neurological impacts of childhood trauma and health risks adopted to cope. After determining people's individual ACE scores, they compared these ACE scores with the histories that Kaiser had collected on each patient. What they found was that the higher the ACE score, the more types of trauma, the greater the impacts on the brain and nervous system, and the more frequent the adoption of serious health risks. Neurobiological effects of trauma include disrupted development, difficulty controlling anger and rage, hallucinations, depression, panic, anxiety, somatic problems, sleep problems, impaired memory, dissociation, and flashbacks. Health risk behaviors include smoking, obesity, physical inactivity, suicide attempts, alcoholism and drug use, multiple sex partners over 50, repetition of original trauma, self-injury, eating disorders, and the perpetration of violence. These behaviors are viewed by the ACE study not as symptoms or bad habits or self-destructive behaviors necessarily, but rather as attempts to cope with, get release from, or lessen the pain caused by childhood trauma. Now we come to column 3, the last column on that one-page chart of yours. The ACE study found graded relationships between adverse experiences in childhood and chronic health conditions, including ischemic heart disease, autoimmune disease, lung cancer, COPD, asthma, liver disease, skeletal fractures, and socially transmitted diseases. Multiple traumatic childhood experiences also increase the possibility of experiencing adult social problems, including homelessness, prostitution, delinquency, criminal behaviors, inability to sustain employment, re-victimization by rape and domestic violence, compromised ability to parent, negative alterations in perception of self and others, alterations in systems of meaning, intergenerational transmission of abuse, and long-term use of health, behavioral health, correctional, and social services. Now this slide is another way of it's a simpler way, and it's one used by the ACE study folks. They don't use my graph that much. But it kind of gives you a visual to understand the ACE study. ACEs on the bottom of the pyramid underlie disrupted neural development and social, emotional, and cognitive impairments. These in turn can cause the adoption of health risk behaviors, which are often precursors to disease, disability, or social problems, and they lead to early death. Okay. So now that you have an overview of the ACE study, I'm not going to stop here. I'm going to give you a lot of different examples of the multiplicity of ways in which childhood trauma can manifest. Please note in the following slides the consistently graded relationships are dose-response relationships in which it is clear that the ACE score shown at the bottom of the graphs, you know a person's ACE score from 1 to 10 that we talked about, the more the likelihood is of developing problems across the lifespan. So we'll start with emotional pain and mental health problems. Childhood experiences underlie chronic depression. The ACE study found that adult men and women with an ACE score of 4 or more were 460% more likely to be suffering from chronic depression. It also found that women are twice as likely as men to experience episodes of major depression over their lifespan. However, men, for many reasons, significantly underreport their experiences of depression. And the way it's defined in the DSM-4 doesn't really describe the kind of depression that men experience and how they express this. So they're probably underreported in the ACE study. Childhood experiences also underlie suicide. Note the graded relationship. The higher the ACE score, the more the likelihood of ever attempting suicide. The likelihood of adult suicide attempts increased 30-fold, or 3,000%, with an ACE score of 7 or more. Childhood and adolescent suicide attempts increased 51-fold or 5,100% with an ACE score of 7 or more. Now, you might think it's kind of tough to get an ACE score of 7, right? I see somebody saying, no, no, it's true. It's not tough to get a score of 7. Imagine if you're physically abused or sexually abused, more than likely there's emotional abuse, more than likely there's neglect of both kinds, more than likely there's somebody in the household who is addicted to something, there's somebody who's in prison, there's somebody is emotionally disturbed, there's likely to be breakup of intimate relationships. So you've got a lot of things going on usually. It's not hard to get a score of 7. The ACE study analysis of the data found that 2/3 of all suicide attempts, 64% of adult suicide attempts, and a startling 80% of child-adolescent suicide attempts are attributable to cumulative childhood traumas. The study also found the lifetime prevalence of having at least one suicide attempt was approximately 3 times higher for women than for men. However, we know from other research studies of the general population that men are 4 times as likely to actually succeed in taking their lives. Now, this is something that until I did a job with a group of American Indian and Alaska Native peoples in Alaska, where many different representatives came together. I didn't know this, and I was blown away by this data. Of the many types of childhood trauma, research shows child sexual abuse to be the strongest and the most independent risk factor for suicidality, accounting by itself, without the other risk factors involved, by itself for between 9 to 20% of suicide attempts. This is most strikingly demonstrated among young American Indian and Alaska Native populations, girls and women. In general population studies, we find between 1/3 and 42% of all girls are sexually assaulted before the age of 18. By comparison, nearly 80% of American Indian, Alaska Native girls are sexually abused in early childhood. 80%. The relationship of child sexual abuse to suicide then becomes apparent in the fact that among all young females between the ages of 5 to 34, young Alaska Native American Indian women have the highest rate of suicide, over 3.5 times as high as the general female population, including other minority groups. So any program, and this is a big thing of mine because I've reviewed some of the programs in Maine, any program that seriously aspires to prevent suicide over the long term must openly speak about adverse experiences during childhood as a contributing factor. The challenge, of course, is finding a way to incorporate this sensitively into trainings and educational materials. But if this issue is silenced or left out, long-term, short-term might work, but long-term prevention of suicide, forget it. If this issue is left out. So we have a responsibility here to do something about our suicide prevention programs. Iraq combat veterans, as Peter was mentioning before, according to a 2008 report by the Armed Forces Medical Examiner, among Iraq war veterans, more troops have died by suicide than in combat. Not only that, but 36% of the suicides were troops that were never deployed. Very interesting findings. The ACE study was the first study to assess the relationship between mental health outcomes and adverse childhood experiences among soldiers recently returned from combat. And when Vincent Politi met for the first time with a large group of combat veterans from Iraq, there were more tears and more weeping in the room than with any other audience that he had talked with. The study confirmed the high prevalence of ACEs. 53 to 54% of these combat veterans and even pre and post deployment reported at least one ACE, and 29% reported 2 or more. The results showed that individuals who reported 2 or more traumatic experiences were at increased risk of developing depression and PTSD. And this held true for both pre- and post-deployment samples. This highlights the importance of considering childhood traumatic experiences as well as the level of combat exposure when treating symptomatic military personnel returning from war. Another slide that shows the relationship between childhood sexual trauma connected to multiple somatic symptoms. Often women who suffer multiple and painful bodily symptoms for which medicine can find no physical explanation, and they make frequent visits to professionals seeking help for these symptoms. They're often called attention-seeking or crazy or playing the victim or otherwise negatively criticized or judged, right? I mean, you know, you're not sick. What do you keep coming to the office for with all this stuff? However, what one sees is that the presenting problem in the physician's office is often only the marker for the real problem, which is child abuse, which lies buried in time, concealed by patient shame, secrecy, and sometimes amnesia, and frequent clinician discomfort. That's a big factor. So, are we misdiagnosing in the mental health field? Hallucinations often get mistaken for psychosis or symptoms of schizophrenia, right? Versus being a neurological response to trauma. And so the root causes are overlooked, misdiagnosis occurs, and treatment, as we all know, is frequently ineffective. The ACE study found that compared to persons with 0 ACEs, those with a score of 7 or more had a 5-fold increase in the risk of reporting hallucinations. Bruce Perry of the National Child Traumatic Stress Network notes that abuse and trauma suffered in the early years of development result in a far greater likelihood of pre-psychotic and psychotic symptoms. Further evidence that adverse childhood experiences affect mental health is demonstrated in these bar graphs, which portray the adult use of antidepressant, anti-anxiety, and antipsychotic prescription drugs. Note the graded relationship between the more the ACE score, the more the need for and use of these drugs, indicating increased rates of depression, psychotic disorders, and anxiety, of course. So as Peter mentioned before, up to 98% of adults with serious mental illnesses, such as schizophrenia, bipolar, borderline personality disorder, blah, 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 and 93% of adolescents in psychiatric hospitals have histories of physical, sexual, and emotional abuse. Yet they are seldom questioned about or assisted in dealing with their childhood trauma. Again, we jump to what's wrong with the person rather than what might have happened. The shattering of the self. I'll go over this very quickly. Judy Herman, excuse me, on what, page 121, I know it by heart, in her book, Trauma and Recovery, identifies all these alterations that happen as a result of childhood trauma. Alterations in affect regulation, for example, the feelings of illness, preoccupation with suicide, self-injury, explosive or inhibited anger, compulsive or inhibited sexuality. Alterations in consciousness, amnesia, dissociative episodes, depersonalization, reliving of experiences. Alterations in self-perception, which I'll go over in the following slides in just a minute, because I think that's a really important one. Alterations in perceptions of the perpetrator, a preoccupation with the relationship and an ascription of total power to that person, idealization sometimes, thinking the relationship is special, acceptance of the perpetrator's belief system are his or her rationalizations. So, and then alterations in relationships with others, isolation and withdrawal, disruption in intimate relationships, repeated search for a rescuer, that's something I hear over and over again. And that may also alternate with withdrawal. Persistent distrust and repeated failures of self-protection. Alterations in systems of what gave life meaning, the loss of faith, the development of despair. So for a full definition, you can go to Judy Herman's book, but I just wanted to go over some of the self-perception ones because I saw these so vividly in Anna's history, and I also see them in my own often. These next slides use some of my daughter's artwork to portray the feeling behind these alterations. A sense of helplessness, paralysis, captivity, inadequacy, powerlessness, and a sense that things are dangerous, a lot of fear. A sense of shame, guilt, blaming oneself for the abuse, and a sense that one is bad. A sense of somehow being defiled or contaminated, spoiled, degraded, and even sometimes a sense of thinking of oneself as evil. And then a sense of a complete difference from others, isolation, aloneness, the belief that no other person can really understand, which is one of the things that my daughter experienced in spades. She never disclosed her history of sexual abuse. She was never given an opportunity to for all those years, and thought she was the only one in the world, and therefore, well, you finish the sentence, therefore a lot of things. So here we come to coping. So what are the ways? I mean, this is a lot of pain, okay? What are some of the ways that we use or have used to cope with emotional pain and stress? Any ideas from you all? Just shout out if you can think of anything. I'll think of one thing for myself. I used alcohol, okay? That made me feel better, right? Anybody else? Sugar. Good. Cutting. Yes. Drugs. Is that what you said? Drugs, yes. Sex. Exactly. No sex. Another way. Gambling. Good. This is the first time I heard that brought up. Exactly. Anything else? Shopping. Oh, yeah, I know that one. Internet. Workaholism. Exercise. Lack of exercise. Both. Anything else? Not eating. Okay, these are all ways that we use to cope and to make ourselves feel better. And they almost work, don't they? Almost.
How about religion?
Religion can be. Of course, anything can become an addiction. Anything can become a way of either numbing ourselves or feeling better. All right? So, this kind of pain obviously leads us to find ways of relieving it. But some of the ways, although they almost work, they put our health at risk, right? The most common among these being smoking, alcohol, and drug use. And these were looked at very closely by the ACE study. What they found was that a child with 6 or more categories of adverse childhood experiences is 250% times more likely to become an adult smoker. Not only is the child more likely to become an adult smoker, he or she is much more likely to start smoking early in life. So, with a score of only 4 categories of adverse childhood experiences, individuals are 260 times more likely to develop COPD, chronic obstructive pulmonary disease. And now we come to adult alcoholism. There is a 500% increase in adult alcoholism directly related to adverse childhood experiences. Note again the dramatically graded relationship. The more the ACE score, the more likely alcoholism. The ACE study analysis found that childhood traumatic events underlie 2/3 of all alcoholism. And additional research shows that teenagers with alcohol and drug problems are 6 to 12 times more likely to have been physically abused, and they are 18 to 21 times more likely to have been sexually abused in early childhood. Also of note is a SAMHSA study that reports 75% of adults, and especially women in substance abuse treatment, have been sexually abused as children and adults. One of the strongest relationships seen was between the ACE score and alcohol use and abuse. Given recent research indicating the negative impact of alcohol use on neurodevelopmental process of adolescence, the relationship of ACEs to early initiation of alcohol use, shown in this graph, is particularly worrisome, right? Right, while their brain is still developing, they're using alcohol as a way to treat themselves, actually, for what they're not able to deal with. The negative health and social consequences of alcohol abuse and alcoholism constitute a major public health problem, and ACEs have a particularly strong association. In addition, it's notable that the perpetration of the cycle of alcohol abuse appears to be tightly interwoven with the number of ACEs, including eventually marrying an alcoholic. So we do tend to repeat these patterns. Intravenous drug use. A male child, I just find this so sad. A male child with an ACE score of 6 has a 4,600% increase in the likelihood that he or she will become, or he will become an IV drug user later on in life. 78% of drug injection by women can be attributed to their experience of cumulative trauma in childhood. Again, relationships of this magnitude are rare in epidemiology. This was very startling for the investigators. So again, the ACE study demonstrates the basic cause of addictions is predominantly experience-dependent during childhood and not substance-dependent. Another example we have here is the likelihood of 50-plus sexual partners, which can lead, of course, to increased likelihood of sexually transmitted diseases, and now we come to serious social problems. By increasing vulnerability and weakening resilience, cumulative adverse experiences lead to difficult, heartbreaking, and often re-victimizing social problems. Now keep in mind here that not everyone with a history of childhood adverse experiences develops these problems and outcomes as adults. Some people with high ACE scores have been helped early on, or have high resiliency, or have become aware of the impacts and have taken steps to prevent them or to change their health risk behaviors. However, most with a history of ACEs are negatively impacted in some way. So we have this, in the next slide demonstrates that children exposed to violence often grow up to become victims. Women with an ACE score of 4+ are almost 900% more likely to become victims of rape. And they're almost 500% more likely to become victims of domestic violence. So just as the risk of becoming a victim of domestic violence rises with the number of ACEs, so does the risk of perpetrating domestic violence. This is true for both women and for men. Unwanted pregnancy or elective abortion, very interesting data that show that sexually abused male children, the younger they're sexually abused, the more likelihood they are to have impregnated a teenager. And it found that among women, the higher our ACE scores, the more likely unintended pregnancies and elective abortions. Worker performance is impaired, our ability to work. The higher the ACE score, the more we were abused or traumatized as children, the more likely it is that we'll experience difficulty on the job, as seen by reports of absenteeism, serious financial problems, and on-the-job problems. Adult homelessness is another factor that can link directly, even considering the social context that allows for the existence of widespread homelessness. Even in that environment, still, those more likely to become homeless have large histories of abuse in childhood. What the ACE study found, that if a child is neglected, he or she is 13 times more likely to become homeless, or to experience that during adulthood. If a child is physically abused, he or she is 16 times more likely to experience homelessness. But then it found that if a child is both neglected and physically or sexually abused, both, they're 26 times more likely than those who haven't experienced that abuse to become homeless during their adult lives. Childhood trauma and adult violence, although not all abused children grow up to become abusers, of course, there's a strong correlation that those who are seriously abused will become the most violent members of our society. A seminal study of juveniles sentenced to death found that each individual had suffered severe physical and sexual abuse. In the majority of cases, this abuse was of a repetitive nature and often perpetrated by more than one family member. Another study found that over 83 or almost 84% of convicted killers suffered severe physical and emotional abuse, and 32% were sexually violated as children. Girls and women considered dangerously violent are 2 to 7 times more likely than female controls to have been exposed to violence in childhood. And children from violent homes are 24 times more likely to commit sexual assault than their counterparts from nonviolent homes. And now we come to adult disease and disability. Have I thoroughly exhausted you all so early in the day? Again, I'm really showing you the full scope of ACE study findings. And please, know that they're available to you, slides and notes. Take them and use them. Okay, we've discussed the relationship of high ACE scores to adult health. The more adverse and traumatic events in childhood, the more likely an individual will develop these serious health conditions later on in life. Now, there's more on this that indicates in the literature that some of these health conditions, most particularly coronary disease, there's a direct link to the adverse childhood experiences, even considering the health risk behaviors, even factoring those in. There's a direct link from the stress caused by childhood experiences and the development of these very serious illnesses. And finally, poor life expectancy. The ACE study found that those suffering substantial childhood trauma have double the risk for early death compared with adults who have not endured such childhood experiences. On average, children exposed to 6 or more ACEs died at the age of 60, whereas children without ACEs died at the age of 79 on average. So a traumatic childhood may take as much as 20 years off of a person's lifespan. These are the many, many, many faces of trauma. I'll just mention a few basic steps that can be taken to improving services to deal with trauma. The first basic step is to start with a universal assumption. I think Peter mentioned this. A universal assumption that everyone in services has a trauma history. Just start with that assumption. You do a whole lot less harm that way. A second basic step is to become knowledgeable about childhood trauma and its many possible impacts so that you can convey genuine understanding and empathy to the people that you work with. All the other, treatment methodologies aside, if you can't convey that verbally or non-verbally, you really can't be effective. So understanding the role of trauma is very important. A third basic step is to take every precaution possible to avoid re-traumatizing individuals who've already experienced so much emotional pain and upheaval to their nervous systems. And this means modifying every aspect of your service system. So I want to suggest that the next conference you do be centered around how to create trauma-informed organizations and climates for both staff and clients. Both staff and clients, yeah. Because staff are incredibly traumatized, often in childhood and by the nature of the services that they're delivering and the climate in which they're delivering. So it's a really, really important issue. Without having trauma-informed organizations where the climate is safe for people, we do inadvertently, even though we're trying to do good, we do harm. We inadvertently close the door behind a person coming in to see us in their office, not having a clue that they really need to make that choice themselves. You need to ask, are you more comfortable with the door closed or open? Maybe their perpetrator took them inside a closed door room. You see, that's an obvious one. There are a lot of other really obvious things. So I want to go back to that questionnaire that I asked at the very beginning. You see how many slides I've gone over. How about this one, reflection? Let's do another reflection. And I want to ask you the question, if you were going to kind of, put yourself on a continuum, is substance abuse and addiction more a disease or more a manifestation of trauma in childhood? How many of you think that it's more on the side of being a disease? How many of you think that it's more on the side of being a manifestation of childhood trauma? Can I see a show of hands? Oh. A show of hands for how many of you think it's more a manifestation of trauma in childhood? Thank you. Thank you. And how many of you think that at this point that mental illness is on a continuum? How many of you think that mental illness is primarily a disease? It would take real courage for you to raise your hand. Thank you. And how many of you think that mental illness is really more a manifestation of childhood trauma? And thank you again. Thank you for your courage in disagreeing with the crowd, because that is really important. Okay. Thank you so much. I never know how to end these things. I don't even know how to say goodbye to people when I leave. So I'm just going to end this now. And if you'd like to discuss this further, I'm here through lunch. There are resources listed in your slides. They're wonderful resources. If you go to the Anna Institute website, there's a whole bunch of stuff there about models for trauma-informed care, models for trauma-specific treatments. And thank you, thank you, thank you.